alongside Ashish Jha, Dean of the Brown University School of Public Health, and Jack Elias, Dean of Biology and Medicine and Senior Vice President for Health Affairs, both of whom could not be here today, I'd like to welcome you to the Paul Levenger Decoding Disparities seminar series. This seminar series is part of a joint effort between the School of Public Health and the Warren Alpert Medical School to focus on the inequalities and health disparities that exist in healthcare today. Although health disparities are certainly not a new issue, we are now at a moment in history when unprecedented public health crises and mass movements have collided to shed light on centuries of systemic racism in the United States, including within the healthcare industry. As academic healthcare leaders, we have a responsibility to build community awareness and create a safe space for current and future healthcare professionals to discuss economic and racial discrimination and inequity. This lecture series is a part of that effort. Our goal for you after this lecture is that you will have a better understanding of where we need to make progress and what still needs to be learned as we work to close the gap on racial, economic, and social disparities of healthcare in America. Before I go any further, I'd like to thank those who made this series a reality. I'd like to thank my colleague, Sharon Rounds, Associate Dean for Clinical Affairs at the Medical School, who worked alongside me to create this robust series. I'd like to thank our superstar teams from both the School of Public Health and the Warren Alpert Medical School that have worked tirelessly to bring together a superb lineup of scientific leaders of this topic. I'd also like to thank the members of those teams who continue to work behind the scenes to make this all possible. We are also lucky enough to have this lecture series supported by the Paul Levenger Professor Pro Tem in Economics of Healthcare, which is funded through an endowment established in 1987 to honor the memory of Paul Levenger. The gift was made by his wife, the late Ruth Levenger, their daughter, Betty Levenger Cohen, and her husband, Dr. John Cohen, a pediatrician, Brown, class of 1959. We are pleased that Betty and John have been regular attendees at other Levenger lectures over the years and will be joining us again throughout this series. It's support like that of the Cohens that allow us to continue to do this important work. Now I would like to invite Sharon to introduce today's very special speaker, Dr. Juan Celodon, whose research goals are to identify genetic and environmental determinants of airway diseases, particularly in racial ethnic minorities. Thank you.
Truly a pleasure to introduce to you today Dr. Juan Celodon, who's the Niels K. Jern Professor of Pediatrics and of Medicine, Epidemiology, and Human Genetics at the University of Pittsburgh, where he is Division Chief of Pediatric Pulmonary Medicine. Juan obtained his medical degree in Columbia. He served his internship and residency training in internal medicine in New York City. And we're very proud. He was a pulmonary fellow, pulmonary critical care sleep fellow at Brown University Hospitals here in Providence. Following his clinical training here, he completed a research fellowship in respiratory diseases at the Channing Laboratory at Brigham and Women's Hospital and Harvard Medical School, while he also obtained a doctoral degree in public health from the Harvard School of Public Health. Dr. Celodon's work as a physician scientist has been recognized by organizations and institutions in the US and abroad. He has been elected to the American Society for Clinical Investigation, the Pediatric Society, the Association of American Physicians, etc. And we're very, very proud that he is the first Latino and the first faculty member from the University of Pittsburgh to serve as president of the American Thoracic Society since the society was founded in 1905. So we're particularly pleased that he was able to take time from a very, very busy year to come and talk to us today about disparities in respiratory diseases. So I do want to ask the audience if you have questions or comments to please put them in the chat function or the Q&A function, and we'll address them after the talk. And those who wish to have CME credits should log on to the Brown Continuing Medical Education Office website. So thank you very much, and Let's learn some more about health disparities and respiratory diseases.
I have funding from the following federal agencies: the National Heart, Lung, and Blood Institute, the National Institute on Minority Health and Health Disparities, the Centers for Disease Control, and the National Institute of Occupational Safety and Health. I have received research materials from Merck, GSK, and PharmaBite to provide medications free of cost to participants in NIH-funded studies, but I have received no salary support from these companies. Asthma is a very common disease affecting over 300 million people worldwide and approximately 25 million people in the United States. In this country, asthma poses enormous cost to the healthcare system, estimated to be around $81 billion per year. Asthma is a syndrome comprising airway inflammation, airway remodeling, airway hyperreactivity to non-specific stimuli, and airflow obstruction that is often, but not always, reversible. Asthma is not an equal opportunity disease. Certain groups are more affected than others. For example, the economically disadvantaged and certain racial or ethnic groups. Now, in this country, Blacks have more asthma than whites. And if you look at Hispanics or Latinos as a combined group, it would appear as if Hispanics or Latinos have less asthma than Blacks or whites. However, this is a fallacy that disappears once you decompose Hispanics or Latinos into subgroups. If you go to Latin America and you mention the term Hispanic or Latino, nobody will know what you are talking about. As defined by the US Census, a Hispanic or Latino is an individual who can trace her or his origins to lands that were previously under Spanish control. Hispanics can be of any race. Hispanic is an ethnicity and not a race. So here you have 5 individuals who would have to check the box Hispanic or Latino in the US Census. They include Rigoberta Menchú, a Mayan Indian from Guatemala who won the Nobel Prize for Peace. You have 2 former players of the Boston Red Sox, Mike Lowell, who's Puerto Rican of Cuban descent and predominantly of European ancestry, and David Papi Ortiz, who's a Dominican of predominantly African ancestry. Alberto Fujimori would also have to check the box, because even though his parents were Japanese, he was born in Peru. And then you have my comadre, Shakira, who was born in my hometown of Barranquilla, Colombia. She's half Lebanese, half Colombian. She'd also check the box Hispanic. From a biomedical research standpoint, combining these groups is problematic at best. In fact, when you look at subgroups and asthma, Hispanic subgroups and asthma, you have this phenomenon where Puerto Ricans have the highest prevalence, morbidity, and mortality from asthma of all ethnic groups in the US, whereas Mexican Americans have the lowest burden of asthma of all ethnic groups in this country. You observe this phenomenon, the Hispanic paradox, for COPD and premature birth. The territory or state in this country with the most premature births is the island of Puerto Rico. Mexican women deliver the fewest preemies in this nation. You do not see these paradoxical or discrepant findings for other conditions such as obesity and diabetes. Why do these disparities in asthma occur? Well, there are factors at the individual level and the community level. The only one that is not yet modifiable is genetics. Everything else is potentially modifiable. Includes socioeconomic status or poverty, pollutants in the home, including secondhand smoke, diet, dietary habits, exposure to violence and stress, access to and delivery of healthcare, literacy and cultural beliefs. And then at the community level, you have more of the same: socioeconomic status, housing conditions, sociocultural factors, exposure to violence and stress, outdoor air pollution, education, and the wheel goes round and round, so that a given minority patient may be exposed to multiple risk factors. So let's talk about exposure to violence first. This is a recent review that we published in the American Journal of Respiratory and Critical Care Medicine. And we show that exposure to violence at the individual level, pre or postnatally, at the family level, say intimate partner violence, at the community level, say crime, discrimination, or wars or natural catastrophes, exposed to individuals to violence and associated chronic stress, which may cause a healthy individual to develop asthma or an individual with asthma to get worse, with more exacerbations, hospitalizations, poorer control, decreased lung function, and decreased response to bronchodilators. Puerto Ricans are exposed to high levels of violence, both in the island of Puerto Rico and in the US. They also appear to be more susceptible to the detrimental effects of such violence. For example, after the Vietnam War, Puerto Rican veterans reported more symptoms of post-traumatic stress disorder, or PTSD, than veterans in other ethnic groups. Following the events of 9/11, the ethnic group in New York that reported the most PTSD symptoms were again Puerto Ricans. We and others, as I will show you, have linked violence and related stress to asthma and morbidity from asthma. If you haven't been to Puerto Rico, you should visit once the pandemic is over. It's a beautiful island. This is the Fort of El Morro in San Juan. In this first study, we examined the relation between exposure to violence and chronic stress and asthma morbidity in 1,212 Puerto Rican children living in the metropolitan area of San Juan and Caguas in the island of Puerto Rico. In the year prior to the study, 14% of these children had witnessed an act of violence, 7% had been direct victims of violence, and 6% had been victims of physical or sexual abuse. And this is what we found. In a multivariable analysis, we found that physical or sexual abuse in the prior year was associated with approximately twofold increased odds of carrying asthma, medication use for asthma, ED visits and hospitalizations for asthma and allergic rhinitis. To my knowledge, this was the first report of a direct association between abuse and childhood asthma. We postulated at the time potential mechanisms, alterations in the hypothalamic pituitary axis, for example, decreased levels of endogenous cortisol. However, that study was cross-sectional, and we could not firmly establish a temporal relationship between abuse and asthma. It is possible that abuse leads to asthma, or that children with asthma who are sicker may be more susceptible to being abused. However, our findings were replicated in a longitudinal study of African-American women. In this study, African-American young women who had been abused during childhood had a higher risk of developing de novo or incident asthma over a 10-year period of follow-up. This is Dr. Wei Chen in our group, and we'll look at a susceptibility gene for PTSD and asthma in Puerto Rican children. One of the mechanisms for epigenetic regulation is DNA methylation. It's been the most extensively studied. In general, addition of methyl marks to certain DNA bases represses gene transcription, and removing such marks generally, but not always, increases gene transcription. The gene for the receptor of adenylate cyclase activating polypeptide 1 receptor, or PAC1 receptor, I'm going to call this gene ADCY for short, was implicated in the pathogenesis of post-traumatic stress disorder, or PTSD, and anxiety in children by my colleague Kerry Ressler, who used to be at Emory, but is now at Harvard. In a landmark paper in Nature in 2011, Dr. Ressler showed that the more PTSD symptoms quantified in a scale, the higher the methylation of the promoter of this gene. We then asked the question whether exposure to violence may be associated with DNA methylation of this gene in our cohort of Puerto Rican children and adolescents. So in a study of over 500 Puerto Rican youth aged 6 to 14 years, we found that in fact, each 1 point increment in the exposure to violence scale score was associated with increased methylation of the promoter of this gene. Moreover, we found that increased methylation of the promoter of this gene was in turn associated with 30% excess odds of having asthma among these children. We also showed in this paper that a SNP that Ressler had linked to PTSD in adults and childhood anxiety was associated with asthma in this cohort of Puerto Rican children and adolescents. To my knowledge, this was the first study to provide a potential genetic or epigenetic mechanism for the observed link between psychosocial stress and childhood asthma. This is a more recent analysis that we did of data from 24,612 high school students in the US. And what we look at was victimization at a school. We look at 5 types of victimization: fear to attend a school in the prior month, being threatened or injured by a weapon at a school in the past year, being physically abused by a dating partner in the past year, having been ever coerced into sex, and having been ever bullied at a school. In a multivariable analysis accounting for multiple potential confounders, we found that any victimization at a school was associated with 1.43 times higher odds of asthma in these high school students, with very similar effect estimates in males and females. Moreover, we showed a dose-response relationship. That is, the more types of victimization that a student had experienced, the higher her or his risk of having asthma. I will next talk about chronic stress and post-traumatic stress disorder, PTSD. These are 2 children using their inhalers with a spacer, the way it should be done. We know that Puerto Ricans have lower response to short-acting bronchodilators, such as albuterol, than members of other ethnic groups. This has been partly attributed to ethnic-specific variation in the frequency of SNPs in the gene for the beta-2 adrenergic receptor, or ADRB2. However, I found this paper from my colleague Greg Miller at Northwestern, in which he showed that chronic stress alone or accompanied by acute stress was associated with reduced expression of ADRB2 in white blood cells of subjects with asthma. Therefore, we asked the question, could increased stress lead to reduced bronchodilator response, or BDR, in Puerto Ricans? That's what we found. So in 234 Puerto Ricans aged 6 to 14 years who had asthma, we found that high levels of chronic stress were associated with 3.9% lower response to bronchodilators, or BDR. To give you some context, in research studies of asthma, 8% is considered significant. So this is about 50% of what would be considered significant. We then went to a second cohort, the Rhode Island Puerto Rico Asthma Center cohort, which includes not only Puerto Ricans, but also Dominicans and whites. And in this cohort, we found that anxiety and panic disorder, independently or combined, were also associated with reduced BDR. Now, the question that you may be asking is, well, that's because high levels of stress in the child and perhaps the parents leads to non-adherence with prescribed controller medications like inhaled steroids. So to try to address that issue, we went to a third cohort, the National Health and Nutrition Examination Survey, or NHANES, and we found 87 adolescents who had a reduced ratio of FEV1 to FVC, but had no diagnosis of asthma and were using no medications for asthma. And in those adolescents, high levels of stress were associated with reduced BDR. Moreover, we look at stress in the household. That is, households in which both the mother and the child were highly stressed. So when you look at children in those households and you compare them with households in which neither the child nor the mother was highly stressed, these children had 10.2% lower BDR. We then went back to ADCY, the ADCY gene, and did a meta-analysis of SNPs in this gene in relationship to bronchodilator response, finding in this analysis of 2,743 racially and ethnically diverse children with asthma that the SNP was associated with 1.1% lower BDR. Moreover, we found that this SNP that was associated with lower BDR was associated with reduced expression of ADRB2 in white blood cells of children and adults with asthma in an independent cohort called Asthma Bridge. Finally, we had functional MRIs and genotypic data in a cohort of African-American women who had been heavily traumatized and were living in inner city Atlanta. And in this woman, those who had 1 or 2 copies of the allele that was associated with reduced BDR had increased connectivity of their amygdala and insula, which in humans is a radiologic biomarker of increased anxiety. So how do we put all of this data together? We believe that chronic stress is leading to reduced BDR in children through neurohormonal mechanisms, particularly in those who are genetically susceptible. There may be persistently high catecholamine levels. This leads to downregulation of the gene for the beta-2-adrenergic receptor and therefore reduced BDR. These results, of course, have implications for other stress-induced cardiopulmonary diseases such as myocardial infarction. I'm going to now talk about PTSD and asthma. So PTSD had been linked to asthma in cross-sectional studies. In collaboration with my colleague and friend, Dr. Rafael de la Hoz at Mount Sinai in New York, we examined the relationship between probable PTSD at a baseline visit after 9/11 and incident or new onset asthma after 4.5 years of follow-up in a cohort of 3,757 World Trade Center rescue and recovery workers. These workers had never smoked and had never been diagnosed with asthma prior to the baseline visit. And in a multivariable analysis, adjusting for multiple potential confounders, we showed that having probable PTSD at a baseline visit was associated with 2.4 times increased odds of developing de novo asthma over 4.5 years of follow-up. We also found that PTSD at baseline was associated with bronchodilator response. These findings, together with others from our group and other groups, support a growing body of evidence that implicates psychosocial stress in the pathogenesis of asthma and morbidity from asthma. More recently, with Dr. de la Hoz, we'll look at probable PTSD at baseline and wall area percent in high-resolution CT scans of the chest in a subgroup of 823 World Trade Center rescue and recovery workers. In a multivariable analysis in this cohort, we found that having probable PTSD at baseline was associated with higher increased wall area percent, which correlates with airway inflammation. Now, we don't know whether that airway inflammation is allergic or non-allergic, but nonetheless, this is very interesting. I'm going to now talk about depression. And this is a nationwide study, the National Health and Nutrition Examination Survey. And in this study, we'll look at depressive symptoms and bronchodilator response in adults. And what we found was that in adults with carrier asthma, the more severe their depressive symptoms, the lower their bronchodilator response. However, we did not see a relationship between depressive symptoms and BDR in adults without asthma. We also found that the severity of depressive symptoms was associated with increased odds of asthma. And this was independent of the effects of acute anxiety. What we recommended at the time or suggested was that clinicians need to be aware of and adequately manage depressive symptoms in adults with asthma. What about depression in the mother? Well, now in our cohort of Puerto Rican youth, we have longitudinal data in 406 children. They were 6 to 14 at a baseline visit, and we saw them again when they were 10 to 20 years of age. And we had data on maternal depressive symptoms, a quantitative scale called the CESD, at the baseline visit and at the follow-up visit. And what we found was that in children whose mothers had increased depressive symptoms, they had reduced FEV1 and FEV1-FBC over time after adjusting for case control status and type of health insurance. We also found that children whose mothers had substantial depressive symptoms, defined as a CESD score of at least 21 points, at both the baseline visit and the follow-up visit, had a much higher risk, 3.5 times higher, of having had a severe asthma attack or exacerbation in the year prior to the second visit. This was recently published online. I will briefly talk about obesity, and this is work from Dr. Eric Forno in our group. So working with Dr. Forno, we'll look at a population of children and adolescents, the Childhood Asthma Management Program. This was originally a clinical trial to assess the efficacy of inhaled steroids. And we divided the participants into those who were non-overweight and those who were overweight or obese. And we compared children on inhaled steroids, in this case budesonide, to those on placebo or nedocromol. And this is what we found. With regard to FEV1-FBC as an example, inhaled steroids were associated with a higher FEV1-FBC, higher lung function throughout the trial. However, in those kids who had normal weight. However, in those kids who were overweight or obese, inhaled steroids had no effect on FEV1-FBC at any point during the trial. We also saw the same thing for a severe asthma attack. So among non-overweight children, treatment with inhaled steroids led to a 44% reduction in visits to the emergency department or hospitalizations during 4 years of follow-up. Among overweight or obese children, treatment with inhaled steroid had no significant effect on ED visits or hospitalization. Since this paper was published, this has also been shown in adults. This is a landmark paper, in my opinion, published by Dr. Delu Metso and his colleagues in Nature Medicine a few years back. And he had this murine model of experimental obese asthma. And what he showed in this paper was that obese asthma, if you will, in these mice, was driven by the inflammasome and Th17 immunity, not by Th2 or allergic type immunity. Because of this, we wanted to ask this question in humans. And we went back to NHANES and look at data from adolescents. And in these children, we had anthropometric measures such as body mass index Z-score, but we also had data on the fractional exhaled nitric oxide, which is a marker of eosinophilic or allergic airway inflammation. What we found was that in those kids who had low FeNO levels, body mass index was linearly and significantly associated with increased odds of asthma. However, in those kids with an increased FeNO level, there was no association between body mass index and asthma. This suggests that at least in a subgroup of patients, obesity is causing or leading to asthma through non-allergic mechanisms. This is consistent with the murine model. Of course, there are instances where somebody who already has allergic asthma will develop obesity, and there are several types of obese asthma, but this is nonetheless quite interesting. Continuing with the theme of looking at non-allergic mechanisms for obese asthma, we'll look at obesity in relationship to airway desynapsis. This synapsis was defined by Dr. Darren Mead at Harvard as an incongruence in lung growth, whereby lung volumes grow faster than airway caliber. These patients have low FEV1-FBC despite a normal FEV1 and FBC. In this study, we had data in over 4,000 children with and without asthma. We had data on body mass index or BMI and obesity, and we could do cross-sectional and longitudinal analysis. In kids with asthma, we also look at the synapses in relationship to clinical outcomes, and this is what we found. Both BMI and overweight or obesity were associated with increased risk of desynapsis. This was true in both males and females. And interestingly, desynapsis in children with asthma was significantly associated with higher risk of severe asthma exacerbations and of the need for prednisone births for asthma. These findings further suggest that, at least in some patients, obese asthma is related to non-allergic mechanism, in this case, probably lung development. So for obese asthma, the reason I'm talking about obesity is because it's more common obesity in ethnic minorities and the poor. Not all obese asthma is the same. I refer already to this, and the work by Dr. Forno, he has an NIH grant to look at defining these subtypes of obese asthma. Prevention is best. So an obese child will be, in most cases, an adult child. It is therefore criminal to see what's happening with the elimination of physical education classes in public schools and the type of unhealthy diet that these children are obligated to eat. Now, in somebody who already has obesity and asthma, weight management is critical. Briefly talk about diet, and this is Dr. Yuyin Han in our group. And she showed, this is a study again, an analysis in NHANES, that study I've been referred to, where we had pheno data in these adolescents. And we'll look at a measure of the pro-inflammatory characteristics of a diet. It's called a dietary inflammatory index, as being validated. And we calculate this index in NHANES and look at the DII, this index, in relationship to asthma in children and adults. And in adults, we found that a more pro-inflammatory diet, a higher DII, was associated with higher risk of asthma in both adults with and without eosinophilic evidence of eosinophilic airway inflammation, although the relationship was slightly stronger in those with allergic airway inflammation. In children, we found no significant association between the dietary inflammatory index in those with non-eosinophilic airway inflammation, but we found a significant association in those with eosinophilic airway inflammation, suggesting that this pro-inflammatory diet may have stronger effects in those with underlying atopy. We more recently look at this dietary inflammatory index, or DII, in a study, in a very large study of Latino adults called the Hispanic Community Health Study of Latinos. The acronym is SOL. We look at DII and asthma symptoms in SOL using this index and another index, which looks actually at the opposite, a healthy diet. And the DII was associated in a multivariable analysis with higher risk of asthma and higher risk of asthma symptoms in Latino adults in SOL. We found that the over dietary index, which was primarily designed for cancer, didn't have the same predictive probabilities, if you will. However, when we look at lung function, we found that both the DII and this healthy dietary index, if you will, were associated with lung function, and they were consistently associated with lung function. That is, the higher the DII, the lower the FEV1 and FPC in these adults, and the higher the healthy index, the higher the lung function. So carrying evidence, we look at the literature on diet, suggests that really what matters is not specific nutrients or vitamins, but your overall dietary habits, dietary patterns. For instance, consuming a Mediterranean diet, a high consumption of fruits and vegetables, grains, nuts, and low consumption of saturated and trans fats, when coupled with high consumption of unsaturated fats, have been consistently associated with lower odds or lower risk of asthma. Again, going back to my previous point, dietary habits are established early in life, both at home and at school. So education is foremost important, along with sound public policy. So where are we going with all of this work? Well, one area that we're interested in is omics, and in particular epigenomics, as a way to try to see how environmental factors influence asthma, particularly minorities. And we and others have shown that ventilation and expression in nasal epithelium correlate well with those in bronchial epithelium, particularly known as smokers. And it's much easier in population-based studies to take samples of nasal epithelium. So we've been taking samples from nasal epithelium in subjects with and without asthma in several population-based studies. We're doing this because over the last few years, it's been shown that the airway epithelium probably plays a key role in asthma pathogenesis. So this is a paper that we published last year in the Lancet Respiratory Medicine. And one of the most exciting parts of the paper was, we identified DNA methylation markers that were highly and very significantly associated with asthma in 3 cohorts. And then using machine learning models, we identified a panel of 30 markers. And we'll look at where they could classify or differentiate subjects, and these are children and adolescents, with allergic or atopic asthma from controls. And this is what we found in our Puerto Rico cohort, and these subjects were 9 to 20 years of age. The accuracy of these markers was 88%. We then went to a second cohort. These are African-American children living in Denver, Colorado. And in those children, the accuracy was 82%. And in a cohort of Dutch adolescents living in the Netherlands, so 3 cohorts, different geographic locations, different race, ethnicity, the accuracy was 87%. When you compare these to using clinical markers, the accuracy of such panel would be in the 60% realm. Random set of markers, 60% approximately. So this is much better. We can use this approach for longitudinal studies, and in fact, we are going to do that. Starting in January, we have a new grant to look at nasal epithelial omics among Latino adults who are participating in SOL. So we'll get nasal epithelial sample, follow these adults over time, and look at where we can develop biomarkers of asthma exacerbations, response to treatment, asthma control, etc. We are planning to do the same thing in the cohort of World Trade Center rescue and recovery workers. We just completed a study looking at whether exposure to violence and related stress are associated with DNA methylation in a genome-wide study of nasal epithelium and white blood cells from Puerto Rican children and a pilot study in Black youth. We are now recruiting patients to look at the epigenetics of stress-induced effects on treatment response in Puerto Ricans and Blacks. So let's now switch to respiratory health disparities. So what are respiratory health disparities? There are significant differences in respiratory health that are linked to racial ancestry, social, economic, or environmental differences. These disparities adversely affect groups of people who have experienced greater obstacles to health based on their race or ethnicity, religion, SES, gender, age, occupation, mental health, disability, sexual orientation or gender identity, geographic location, or other characteristics linked to discrimination or exclusion. Respiratory health disparities are commonly encountered in the practice of pulmonary critical care and sleep medicine. These are just some examples. I already talked about asthma. African Americans and Hispanics are more likely to falsely believe they have been cured from chemotherapy for advanced lung cancer. Puerto Rican women have the second highest age-adjusted mortality from COPD of all ethnic groups. African American adolescents have a higher risk of obstructive sleep apnea. African American men are more likely to present with advanced lung cancer, and Native Hawaiians and Pacific Islanders are at higher risk for tuberculosis. COVID-19 has only further exposed racial and ethnic disparities in respiratory health. So this is a paper that we recently published in the American Journal of Respiratory and Critical Care Medicine. These are data from June, and this compares mortality from COVID-19 in the US and in several states between Blacks and whites. And you can see that Blacks have a much higher mortality from COVID-19. You see the same thing for Latinos, and very markedly so for Native Americans. Why do we see these disparities in respiratory health? Well, we do see them because the risk factors for respiratory disease are unequally distributed by race and ethnicity. So here are 5 major risk factors for respiratory diseases, such as tobacco smoke, air pollution, occupation, intravenous drug use, and obesity. They are linked to multiple respiratory illnesses, and they are more common among underrepresented minorities. So this is a map of the US that looks at smoking, cigarette smoking by poverty level. And the darker areas are those where smoking is more common. No surprise to this group, cigarette smoking is much more common among those who are economically disadvantaged. And unfortunately, for historical reasons, underrepresented minorities are more likely to be overrepresented among the poor in the US. Now, you can look at poverty, and that's a symptom of the problem. Is the weed, what's above the surface or the obvious. But then you have the underlying causes, the root, what's below the surface, what's not obvious. And those will be structural and social determinants of health. So this is a scheme from a prior paper we published as a position statement for the American Thoracic Society of ATS. So you have to think about causes of exposure. Why is it that a Black or a Puerto Rican person is more likely to be exposed to air pollution, for example? Well, that is because they are more likely to live in disadvantaged neighborhoods that are closer to a major road, and they are more exposed to pollution. Why do they have to live in those neighborhoods? Has to do with things like public policy, access to education, high quality education in particular, racism, that determines this. Because of that, they are more likely to be exposed, whether it's to tobacco smoke or pollution. And this interacts with their genetic background. Their disease risk is increased. Now, we could still intervene through a screening and prevention, but they are also less likely to have access to screening. They become then sick, and they may lack health insurance or good health insurance. And therefore, they have decreased access and decreased quality of healthcare, which contributes to poorer outcomes. Everybody concentrates on this, healthcare insurance, but I tell you many, many more cases of respiratory disease in minorities will be prevented by intervening at this level. So this is an example from this paper on COVID-19. So I'll give you an example, a Black or Puerto Rican woman living in the South Bronx, where I did my internship in internal medicine. That person probably has, a frontline job. She cannot afford to stay at home. Had to take public transportation, say March, April. She was exposed to multiple people. Then she gets to work as a grocery store clerk without any kind of mask or protective equipment. She's exposed, she's infected. She lives in poor housing conditions, crowded, and infects other people in her family inadvertently. She develops the disease, may have difficulties with access to care, may go to a hospital that doesn't run out of ICU beds or doesn't have the resources to convert non-ICU beds into ICU beds, and has a much poorer outcome than a non-minority affluent patient. To eliminate respiratory health disparities, we propose a multi-pronged approach that involves environmental justice. Everybody has the right to clean air, for example, a smoke-free environment. Promoting a healthy lifestyle, advocacy is key at the local, state, and national levels. Of course, we support excellent healthcare for everybody in this country. And underlying all of this is research. In 1993, there was a legislative mandate to include women and minorities in NIH-funded studies. So we'll look at NIH-funded published studies in PubMed on respiratory diseases between 1993 and 2013, so 20 years of follow-up. And we found that less than 5% of NIH-funded publications on respiratory diseases included a substantial proportion of minorities. That is at least 25%. This was low in Latinos and Blacks, but really appalling for other groups, including Native Americans, Native Hawaiians, and Pacific Islanders. This is simply unacceptable. Policy matters. This was an executive order signed by then President Bill Clinton in 1994. Environmental justice had significant impact on the quality of the earth we breathe. Over the last 4 years, it's been under relentless and constant attack. The work that I presented would not be possible without the contributions and talents from many collaborators, both in the US and around the world. Now, you know, when I was starting my career, I can tell you I had an interview at Brown, and one of the people who interviewed me, I asked him whether he could explain to me what his research was about. And he looked at me up and down, paused, and said, "You wouldn't understand." So I did what most people do, which is they look at appearances, you know, the color of your skin, your accent, the place you come from, and they dehumanize you. To them, it's over. You have no right to have any ambition, aspiration, or any intellectual ability. And what those people tend to underestimate is what's in your heart. Passion and determination can achieve the impossible. I've always believed that. So when people say that, you know, achieving equity in health or respiratory health is impossible, I would say to them that that's profoundly un-American. Do not tell me that a country that won 2 world wars, that put a man on the moon, cannot tackle this problem. Do not tell me that. Paraphrasing former President Lyndon B. Johnson, solving problems like this is what America is all about. For America, it's the uncrossed desert and the unclimbed ridge. It is the star that cannot be reached and the harvest sleeping in the unplowed ground. Is our old world gone? We say farewell. Is a new world coming? We welcome it, and we shall bend it to the hopes of humankind. Thank you very much, and I will now take any questions you may have. Thank you.
Truly informative, as is usual for you, I might add. Thank you so much. So we have a comment from Jim Padbury, who is a pediatrician here at Brown, noting that reduced ADR beta 2 has been linked to also to preterm birth in Latinx populations in New York, indicating that this SNP may also be related to other types of disease in pediatric populations. Do you have any comments on that?
That's an interesting comment. You know, as I mentioned, Puerto Ricans have a higher risk of prematurity. And, you know, whether that could be a mediator of this, it's an interesting idea. Prenatal stress has also been associated with prematurity. So in this cohort, the proportion of premature kids is very low, however. So it's nonetheless interesting.
Is there any evidence that relief of stress, such as perhaps improved socioeconomic circumstances, does that can that lead to a improvement in lung function, or even a change in the methylation of the ADY gene?
So that's also a great question. You know, I collaborated with a psychologist here, Anna Marsland, who did a pilot. It's extremely hard, as you can all imagine, to try to manipulate stress, right? Just very difficult. What I would be interested in looking at really is depression. And that's because, you know, it can be manipulated. Obviously, it's have to be done in an ethical way, but, you know, it's easier to manipulate depression, if you will. And there is already, I believe, sufficient observational data in adults and adolescents that would probably justify a well-designed clinical trial. So I would think that's the next sort of logical step in terms of interventions.
Here's another question. Is there any relationship between the gut microbiome and the pro-inflammatory diet?
Yes, it's a great question too, right? So all of these things, there is a complex interplay between diet, microbiome, and obesity as well, right? So obesity, so all of these things are fairly complex. One thing that is interesting, I didn't mention this because of time, it's that when you think about Puerto Ricans in the island, one of the things they don't have, for the most part, is pets. The Puerto Rican kids in this study. And the reason for that is in a lot of apartments, these are low-income people, they forbid pets, which are a source of mammalian feces and therefore can influence microbiome. You can think of this in different ways. And sadly enough, what we found and have published on is that mouse allergen levels, which are relatively high, so that's the only mammal that these kids are unfortunately exposed to, are inversely associated with allergy in these kids, measured objectively. So goes back to observations in Bavarian farms showing that living there has a lower risk of asthma, and therefore the microbiome. So this is an area, of course, of interest as well.
Would you care to speculate on how stress might alter methylation?
I would think, at least from our, studies, that is probably neurohormonal mechanisms, right? So the idea would be that if you have somebody who's susceptible, and I don't think this gene is by any means the only one in this pathway, that these subjects, where they are adults of kids, have these prolonged, strong, persisting stress responses with activation of the HPA axis, and therefore, the sympathetic nervous system, and they have persistent and unmitigated secretion of catecholamines. And that over time leads to downregulation of the receptor. That would be, to me, one of the most logical explanations. And, we, of course, have a lot of work to do to prove this. So,
Just Decoding Disparities lecture from, I believe it's November 16th. Audrey Tierka from the Brown Center for Stress, Trauma, and Resilience is going to be talking about the effects of stress on health disparities. So this is a great segue to her discussion in 2 weeks. Let's see. And then finally, what possible factors in early lung development might lead to smaller, to dysynapsis, airways that aren't big enough to support the rest of the lung parenchyma?
So, one of the, I don't know that we know anything about this, but going back to the observation about prematurity, that would be an interesting thing to study, right? Along with stress and diet and other potential mechanisms. That would be interesting. One thing we did a while back with another mentee, Christian Rosas, was we look with the limited data we have on prematurity. We did show that the kids who were premature and were also atopic had 5 times higher risk of asthma. So we thought about this as sort of a 2-hit hypothesis, if you will. In a way that, there has to be structural abnormalities in these kids and also some immune response abnormalities. But nutrition may play a role.
Is there any evidence that very low birth weight babies are more likely to develop asthma? Because that, I believe, a low birth weight is also more common amongst some of the underrepresented minority populations.
That is correct. Sharon, when you look, we did a review of the literature a few years, I think about 3 years back, with my colleague Jose Castro from Chile. And, you know, one of the most consistent and strongest risk factors for asthma is very low birth weight. So you're absolutely right. Prematurity is a very strong risk factor. And I already mentioned that in Puerto Ricans, prematurity is more common, right? Mm-hmm. Secondhand smoke also, you know, going back to the observations, you know, Puerto Rican women smoke the heaviest. And that also leads to a structural lung abnormalities. So that's another sort of pathway.
We have a question. What is the potential to reverse these findings? Are children who have been exposed to trauma permanently affected? Is there a way to change the epigenetics?
So we do hope that that is the case, right? So one of the things that is very exciting about epigenetics is that's potentially modifiable and reversible, right? And in experimental models, it's been shown. In humans, that's been sort of harder to prove, or hasn't been proven yet. Let me just say, put it that way. But of course, you know, what we would like to do in these coming studies is measure methylation before and after, right? That's sort of the $1 million question. Can you reverse some of this? And I would guess or speculate that you need some time to prove that, right? So it's a great question.
Very good. Well, fantastic. Great talk. Interesting area, and also one of great need to take action to reverse the respiratory health disparities. Thank you very, very much, Juan, and thank you to the audience and to all the people who made this series possible. So we'll sign off now. Awesome talk.
Thank you very much indeed. Good luck to you.